Hello and welcome to my channel. My name is Peter Abraham. I'm a second career registered nurse with a focus in hospice and palliative care. I'm also a certified end-of-life doula through the International Doula Life Movement. If you're new to this channel, welcome. Thank you so much for being here. In this channel, we talk about things related to death and dying. After all, everyone is going to die. That should not be a mystery or a stigma. And it's because of having conversations and being prepared that we could decrease the fear. We plan for birth. We should be planning for death. That should be advanced care plans. It should be asking very serious questions about if I get this or if this happens, then what? So I will have in this channel videos for my fellow hospice and palliative care nurses. This past Monday, the day of this filming is Tuesday, July 29th, but on Monday, the 28th, I try to film it a day in advance. So Sunday, I was filming Monday's video, but we had a video for my fellow nurses, both hospice, holistic, as well as anyone interested. How do I read the FAST scale? For anyone who has dementia, the FAST scale can give you an indication of where they're at in the disease progression, not an indication that they have dementia. If they were not diagnosed, doctors are the one that gives diagnoses, and certainly not an indication for how much longer they have to live. Please watch that video if you want to know more on why I said it that way. We'll have videos for my fellow end-of-life doulas, caregivers, family members, anticipatory grief, grieving. If there's a topic, by the way, that we've not covered, and you're like, Peter, I'm really interested in this, whether it's what's the difference between personal care and assisted living, or assisted living compared to skilled care, please comment below. Comment below. Non-judgmental channel. I appreciate your input. And if this, from what you're hearing, I like this, I want to know more, please subscribe, hit the bell notification. I'm trying to put out videos at least twice a week. Lately, I've been trying to do Monday, Wednesdays, and Fridays, just to help with educational purposes. Keeping in mind, this is not medical advice. And obviously, if you like the video, do like. The topic for today's discussion is going to be two related paths. One is going to be looking at the upcoming continuing education classes that are freely offered through the International Life Movement. If you've taken any of their classes, that's the International Life Movement was the first end-of-life doula, aka death doula school, to require continuing education in order to remain certified. The first. Schools are now starting to, I don't know if copycat is the right word, but see that we're doing the best practice, therefore we should be doing best practice too. And in order to promote, we need to be a lifelong learner. All of these classes are free. So there'll be a segment of the upcoming, here's what's upcoming. And I'm just showing you a small portion of what I have in Canva. I didn't pull them out because they are not free to the public. Here and there, under the purview of Anna Adams, the founder, and other leadership, they may say, Peter, this session is open to the public, and give me a range for what I might charge for the event. The July 24th Dementia with Hospice timing was $10.95, which I believe is very fair for an hour of live education. There were 4 handouts provided. And for those that are part of IDLM, there is a quiz. If you have not taken it, please take the quiz. But then the second portion of the video is going to be going over here's where we're at with the end-of-life care plans for doulas. Including an announcement that it's been expanded, at least for the outline. Now, before we get into today's topic, every day I like to practice, me personally, I try to do 3 pillars of building resilience. Yesterday, keep in mind, I'm filming this on a Tuesday, so Monday, July 28th, was the kickoff of the International Life Movement Summer Summit 2025. Dr. Cynthia Pan, thank you, Dr. Cynthia, if you're watching this, started opening night. It was amazing and wonderful. We had, I think while Anna was sharing, we had 200 or more people sign up. And if you've ever signed up and attended, you might be like me. I sign up, I put it on my calendar, but I forget to set an alarm on my phone. And oh, I missed it. So we did have, I think it was towards 60 people actually attend. And that number did include Dr. Cynthia Pan and some instructors like myself, Ada Adams, the founder, Pam Carter. For any of you interested, Pam Carter, I mean, everyone on IDLM's team's amazing. I'm biased. Pam Carter has been working with advanced care planning for such a long time. Probably, and I'm 62. I don't want to date you, Pam, but probably when I was a teenager or maybe younger, she was doing care planning. And one of the main selling points for the International Life Movement is everyone who is an instructor, part-time or otherwise, has boots on the ground. And Pam has been doing this with love and compassion for decades, decades. And she is having, and I'll be putting in a link in the description below, an advanced care planning class. I hope you join me. I signed up for this. I paid, even though I'm an instructor, I paid. This is how much I value the class. I paid. I did get a discount, but it was still several $100s to pay, not the discount. I paid several $100s because I believe in the value of what Pam is teaching. I cannot wait. She sent out an email today. Please pardon me. These are not highly edited. You know, she sent out, you know, this is what we're going to be looking for. And I'm not, again, I just put it up there briefly because I don't, there is an issue with other schools, whether you want to call it copycat or best practice. But this is an intense August 12th to October 16th, live via Google Meet. Everyone going, we're actually going to be creating our own advanced care plan. Now, I actually do have mine and my wife's done. We went, this is before taking the class. And because we were having other work done, at least that's what I tell myself, we did have ours done through a lawyer. And to be honest, I have a feeling certain things, not because they were negligent, but I think there are certain things were missed because when it comes down to the living will, you don't have to be a lawyer for this. You do not have to be a lawyer for this. And Pam's work is beyond comprehensive. Again, she's been doing this for decades. She's done this for the extreme wealthy and the extreme poverty. Her experience is, I don't even know who to compare it to. And so I'm looking forward to this August 12th to October 16th. There's still time to sign up. But we make our own advanced care plan. We have to draft our own eulogy and our own obituary. It's a little bit intimidating, but in a way, I'm looking forward to it. Oh, while I'm being intimidated. I don't want to take your time, but Penny, our oldest, she's a combination Jack Russell Terrier Rat Terrier mix, and she makes me laugh because if we're walking, and I know I'm going a little bit rabbit trail, but just to give you some insight into me, the person being authentic, but I'll be walking Penny, and this is before we got Bonnie, and here there'll be this large dog that is across the street, and this large dog is like getting the owner trying to lunge to go at Penny. Now, whether to go at Penny to sniff butts, don't understand that, kiss, or just say hello, or to rip her to pieces, I don't know. I was glad that the owner was managing their leash and it was across the street. But my Penny, I'm proud of you, Penny. My Penny was crying like a baby crying, but lunging. I might die, but I'm going to go out there and I'll take it on. I might die. And I'm just sharing that from the perspective that in a way is how I'm going into this advanced life planning class, knowing that I'm going to have to write my own advance directive, knowing I'm going to write my own eulogy and obituary. Part of me is scared, but part of me is I'm going to be like Penny and I'm going forward. Because if you think about it in life, I know this down to the core of my entire being. One of the lessons I've learned doing hospice for a number of years is to try to live a life of least regrets. How many times I've had families say, whether it's upon diagnosis, upon admission, and it's definitely at the end, I wish, I wish, I wish. We can't live life like that. Well, you can try, and many people do, but that's part of why we have this discussion. That should not be a stigma or a mystery. We need to have these meaningful conversations. So before we get into the doula care planning book and the other part of the getting back to the three pillars, this channel I mainly focus on the third, but part of it's like, how do you keep doing this? It's Dr. Cynthia Pan. I know how we got in this rabbit trail. I was talking about the summer summit. No, Dr. Pan, Cynthia, I'm not blaming you, but she brought up about the stigma and the death and dying, and like people like I didn't know this. She was publishing a lot of facts. Do you know, in terms of doctors and their specialties, what specialty has the highest burnout rate of all doctors? Is it the emergency room doctor? Is it the cardiologist? Is it the hospitalist that floats between different floors? I was shocked. The highest, and I believe I'm going from memory, but this is where I'm weird. I remember numbers better than other things. I believe it was 62% burnout among palliative care doctors. Second place, by the way, did go to ER doctors. But this was like a Coke and Pepsi and Dr. Pepper chain. So second place wasn't neck to neck, to be very clear. Wow. And so one of the things she pointed out, and this is a common theme, palliative care, hospice care. How can you keep doing this? Peter, you're like at 62, technically, God has blessed my wife and I in so many different ways. Technically, I could be retired now, technically. For those of you who watched my very first handful of videos, I talked about how my tragedy from a point of view with hospice from the provider end, not the patient end, and how it's not the way that it used to be. And I shared about how we set up our finances to try to supplement things. And I'm so grateful for the people who are buying the books as well. But technically, and this is part of my gratitude story, by the way, technically I could be retired, but why go be a doula? Why be helping people? I've been helping people for a year and a half remotely at no charge. Why? And that's not to say I'm rich. It's just we're doing okay. But why go to be a doula? Why start a business? Why buy? Let's see if you can focus. Maybe one day, maybe 2 days. There we go. Um, why buy business cards? And then yesterday, now focus on my face. Just the other day, I was sharing with you, and I'm going to get to the gratitude in a moment. But I was sharing with you, my wife and Anna encouraged me to be a part of. You can call it a trade show. It's going to be a will event on August 18th. And for that, and pouring my heart into this, not only did I work out? Now, I don't want to take your time by showing you another piece of paper and having the camera focus and not. But I actually went out, like I've not done trade shows in, oh my word, years. And that's back in my IT world for the trade shows. What was the word for this type of marketing material? What's the word for that? And because this is an inside event and I don't know the space, and this is my over compulsive planning, I actually purchased a table runner, a custom table runner, where I'm creating the image for the hanging front, the image for the top. And why pour good money into that? And why get a business phone number? And why do this? And why do that? Why get back into a field where you're going to be surrounded by death, not necessarily day in and day out, but why are you doing that? Number one, I feel called. And number two, I believe it's because by building resilience, we could be in a place that other people might consider messy. And I believe if you have resilience, whatever you call messy, you can work through and survive without wanting to go to extremely dark places and, to be very blunt, kill yourself. Don't do that. So I believe in building resilience. Sorry, I was looking at trying to make a snap decision. These are the only editing I do is to try to trim out silence in the front of two connecting videos. Um, but here, my faith in Christ Jesus is my pillar one. Forgiveness, something I've been really, really working on in 2025. Not that I've not done it in previous years, but I'm really, really struggling compared to other years. If you watch my earlier videos and see some of the stuff I went through, um, it's challenging to forgive people. And then I think I forgave them. God, I forgive them. Like I'll say it and I'll pray about it in days or weeks, and then the memories will come back, and then I'll start having feelings of anger or frustration, resentment, and I have to pray again. And so there's that. And then there's the third pillar of gratitude. So in terms of grateful, and I'll try to keep this quick because it's already long for the intro. I'm grateful for you, each and every one of you, putting up with my long videos. I'm grateful for the opportunities that have been coming up. I mentioned about the 18th, but my attorney that did our not just our living will. I mean, I'm sorry, yeah, she did our living will. Our advanced directives, our power of attorney. She did. We set up a trust as well. So we did a lot of different things, some of the which did need an attorney to be a part of. And here, that attorney, Sarah, I believe you might go by Sarah James, she's part of a networking group specific to chronic illness and end of life. So this networking group that meets for coffee once a month, and they meet at different locations. This past Friday, what was that Friday? I believe the 26th. They met at Hospice Care Plus Compassionate Care Center in Richmond. And I don't know where they're meeting in August. I'm still trying to work through that. But it might be at a personal care home or assisted living, skilled nursing, or maybe a third-party caregiver agency. The person running this is part of, I think it's Center Well, if I'm remembering the name of the organization. But Sarah James put me in contact with Laura, not my wife Laura, but put me in contact with Laura, and I reached out. I would like to be a part of these conversations for two reasons, and this is part of the gratitude story. And for my fellow end-of-life doulas watching this, I'm trying to share this journey with you, not just to promote my books, but to give you insight of what you too can be doing if you're not already doing it. But I shared, and this is not word for word because I didn't bring the email up on the screen, a short-term memory, so this could be a modified version from what I remember, is for every place I go, I do want to learn what are their referral needs and what are their referral processes and how do I engage their intake department. Because as I get clients in Madison County, Kentucky, there's going to come a point in time that the family, the person in charge, whether that be the patient or the POA or the family member that's been appointed, they get the final say. I don't make the decision for them. But I am part of their education and research arm to guide them, and what they do with it will be as they will. It's their journey. They're in charge. So I want to be able to point them to different places that may be a fit. So I want to be part of the ecosystem. And I also shared, I want to find out from them how to work with them for cases where they believe I might be a fit. And even though I use the word end of life doula, and I'm not going to bring up my business card again on the focus issue, I like to refer myself as a life coach or life transition coach, life transition support guide, because an advanced care plan is part of why I'm taking Pam Carter's class. Is even though I have the paperwork that I could be doing, I am offering it now as a service, but I want to be better at it. So I'm grateful that Sarah connected me to Laura, and Laura accepted me into their team. So she said, I'm putting you on the email chain. She said, our next meeting is on Friday, August 29th. And she said, Peter, would you like to present? For any of you who are watching from the encouraging point of view angle, I said yes. I said, do you want a 15-minute presentation or more? We need to get out there in the community. We need to engage. We need our feet on the practical ground. I know there's some of you who do this work remotely. But to the degree that we serve our local community, I believe we need to be out there. So I'm grateful for that opportunity. I'm grateful for God giving me the courage that I'm an introvert. I can share embarrassing, at least to me, horror stories where it's like I drove somewhere, sometimes a long distance, only literally to run away because my anxiety went through the roof. But I feel called. And a lot of the people that I talk to that are either they're on their journey to become an end-of-life doula, please reach out to me, connect. You don't have to go to IDLM if you don't want to, but I don't mind brainstorming with people. I believe I'm here to serve, and I'm doing that as I'm able. And I don't want to go on much longer because it'll be too long a video to begin with. But engage, get out there. So without much further ado, let me go into the continuing education, the end-of-life care plan book. There won't be a formal outro. Thank you so much. And until next time. Before we get into today's video, which is looking at care plans for end-of-life professionals, specifically doulas, I did want to share the upcoming continuing education classes as well as some past ones that's freely given to students of the International Dual Life Movement. So if you've taken any class, regardless of what you paid for the class with the International Dual Life Movement, you have the opportunity for lifelong continuing education at no charge. These are typically given once a month. In August of 2025, we're going to have actually 2 sessions. Sunday, August 10th, 5 p.m. to 6 p.m. Eastern Standard Time. We'll be looking at palliative care, specifically for end-of-life doulas. How do we recognize when early adoption of palliative care would be very helpful? What are the top 5 diagnoses most commonly seen in palliative care? How do we have these communications with the family to really encourage palliative care adoption? And please keep in mind, even though the words hospice, I shouldn't say the words, hospice is based on a palliative care philosophy. Palliative care just means palliating or symptom managing, making one more comfortable. Palliative care does not require a terminal diagnosis or life expectancy requirement. And many of us in the healthcare industry, whether as a medical support person or a non-medical support person, strongly believe that early adoption of palliative care would reduce the push or the demand or drive, depending on your wording, for medical aid in dying. If somebody is comfortable throughout the entire life cycle process, there would not be like, gee, we treat our pets better, because there would be minimal suffering. I can't ever claim to remove all suffering, but if you can go through coughing spell or allergy season, or even the flu, it's suffering, but not desiring to kill yourself because there is an end in sight and your symptoms are minimized, there'd be less of a demand in that area. So August 10th will be palliative care. August 24th will be supporting the transition from palliative care to hospice. Again, these are free continuing education courses. IDLM, the International Life Movement, is the first school to have ever required their graduates to have continuing education to maintain certification, to be able to claim that they're a certified end-of-life doula. Other schools are starting to catch on, but IDLM was the first, and they're doing it for free. While there's, for what I'm about to share next, there's not yet assigned dates. We did have the hospice eligibility back on June 26th. We had the dementia care and timing on July 24th. That one was open to the public for a small $10.95 fee. And then the remaining courses, I'm still working on more. There's only a handful of here that's already developed, but before I guess over the next few months, I don't want to give a timeline and then fail to meet it. I'd rather exceed the expectations rather than fail to meet them. Like I'd rather uh, under promise and over deliver versus over promise and under deliver. But I have a to-do list of a whole series, a 13-month series, or I should say 13 classes, because we are doing 2 in August. In a way, it's a 12-month. But in terms of like looking at the future, I don't know what order these will be in the future. I'm still working with Anna Adams, the founder, Robin and Pam and other executive leadership. But there's going to be HIPAA compliance, even though non-medical support personnel have wiggle room. Oh, HIPAA only applies to medical support person. From an ethical perspective, I strongly believe that every doula out there should be getting 2 pieces of paperwork completed: a doula liaison form, which gives us permission to contact healthcare providers to gather information, and a HIPAA release form that is state-based. You have to know your states. State-based form uh, giving us permission to share what information and to whom. I do believe that builds trust. It establishes us in the ecosystem that we're a part of, that we're part of this system. We're collaborators. We're not competitors. We're collaborators. There's going to be a professional boundaries and looking at self-care. There's also, and by the way, I tried to find a way to get this sorted. It says newly edited. No matter how much I tried, I did edit that. It wasn't a day ago. I could not have that. I was trying to have dementia care and hospice eligibility towards the end, technology. But there's also one on conflict resolution with patient advocacy. So those of you who've been watching my videos, I like to be transparent. This is not going to be the same as dealing with combative patients. It's dealing with conflict with family dynamics. Sometimes there will be patient conflict, but it's not exactly the same thing as having a combative patient that may explode at you at any moment. I do have on my to-do list to consider writing a continuing education session for that as well. So we're going to be moving on shortly to care plans for end-of-life doulas, but just letting you know that if you take any class with the International Doula Life Movement, any of their paid classes for life, you can take free continuing education sessions. These sessions are given live via Google Meet from August through December. They will be on a Sunday, 5 p.m. to 6 p.m. Just forewarning you, sometimes there's very lively and healthy discussion for maybe a half hour after that if you're very time conscious. Next year, we're probably going to go back on track for being a different day of the week. Not sure. And some of the events down the road, I don't know which ones, because I try to stay within my scope of practice. I try to stay in my lane, so to speak. I'm only in charge of me to a degree, but I'm hoping that Anna and the executive team may say, Peter, this would be another good one to open up for the public for a small fee. I just believe that gets the word out for the international life movement. It lets you know about upcoming courses, like I will be developing a course for the crucial end of life conversations, 14 to 16 weeks, hopefully to be released for early 2026. Now let's switch gears and bear with me, because rather than pausing the recording and editing, I'm just going to be alt tabbing and hoping I don't goof things up too greatly. And actually wanted to come back here first and go over the outline. So last week, I think it was last week, where I showed you the original outline for this book. There was only going to be 17 chapters, I believe, and maybe it was 19. It was the last chapter I shared. I was probably going to be pulling out because it dealt with legacy work, and I do have a book, Crafting Meaningful Legacies, that not only presents 50 plus legacy project ideas, but uses the SMART specific, measurable, attainable, realistic, time-specific goal format, along with resource materials. There's chapters based on prognosis, giving you ideas of what different legacy work you can do. But after working through the writing of this, I made the decision that the original foundation for chapter 8 was going to be all of the neurological disorders. No, that's too much to do for one chapter, and it's not fair. Anyone who knows me in the book, you've been buying my books, thank you so much, and reading them, and thank you, promoting them, thank you, knows I try to give good value for what I'm putting out there. So I really want this to be a book that's in the bag or tool chest for every end of life doula out there. I know that's ambitious from a point of view. So I went over and let me go down, because you saw the previous chapters up until 8. I figure, okay, chapters 8, even though Alzheimer's disease is a specific type of dementia is an umbrella term of at least 13, if not more, types of dementia. Figure let's have this just deal with dementia. Chapter 9, we're going to be dealing with movement disorders. Parkinson's the major one for that. But there's other movement disorders, essential tremors, I'm sorry, super, oh my word, I'm going to goof up the super nuclear one for that. But chapter 10 is movement disorders. Chapter 9. Chapter 10, stroke and brain injury. Chapter 11, progressive neurological conditions. These are not yet written. This is a work in progress. Then this gets back on track, but I did renumber the chapters in part 3, which is the emotional and social, which is so critical. I appreciate. I was watching a video with the End of Life University on YouTube, and the lady had interviewed Dr. Kevin Dieter. Dr. Kevin was so kind to come on the dementia care and hospice timing education class that I had developed. And thank you, Dr. Kevin, for your kind words about the work that I did. I appreciate your sharing that it was very practical and on point. Um, I always appreciate constructive criticism. And I wasn't sure. I did my best, and I wasn't sure if there was anything like, Peter, you missed that, or you could have done this better. But I appreciate, Dr. Kevin, that you were just so kind with your words, and everything was spot on. So thank you. Um, but this is going to be so important when we get into these chapters. Loss of independence, how many loved ones who they may not even have a chronic illness, and they're already isolated in their home. And this is not just for the for the patient. The caregivers often go through this, where it's like, I'm stuck with my loved one, and they love them deeply. They're taking care of them in their setting, but it's like some of them feel like they're trapped there forever. They don't know when it will end. Body image, physical changes, fear of dying and anxiety, spiritual fears and faith struggles, forgiveness and reconciliation. This, by the way, is going from a guide into what would be a standard book, in my opinion. Salvation, grace, eternal questions. And as I shared before, I do not proselytize. If I had my way, not through proselytation, everyone would believe, as I believe, that Christ Jesus is the Son of the only God, the only Son, and that there's only one way to heaven and earth. I'm sorry, to heaven. But I don't proselytize that. I don't push it. So I will be covering, I've not written this chapter, so I'm not sure how I'm going to bring in the different religions. I do believe faith and religion are night and day. Religion is dogmatic, rule-based. If you obey the rules, you might get the reward, so to speak. Um, Fellowship, spiritual community, complex family dynamics, crisis planning. I did add to the appendices, where I will be adding an appendix for the risks, the concern problems, the risk for the major diagnoses that we typically see in the last few years of life, including diabetes. Diabetes is not a terminal diagnosis, not to ever mislead anyone, but it's so common, especially in the US. A sample intake form. I'm going to be sharing mine that I modified from IDLM. Gives you so many free resources, but I took those. I'm going to be actually working. Actually, it's not theirs. It's Kentucky's, on their Kentucky HIPAA form. It's on my to-do list to make it more mine while keeping Kentucky law in place. Um, and then these other appendices may or may not change. I've shared, for any of you who've watched my previous videos on my book writing journey for other books I've written. When it comes to the appendices, this is murky water. I've outlined everything, um, and I just we'll see when it comes to that. Okay, so let's go back here and go into, I just wanted to take you through, I won't take you through every chapter written so far, but chapter 2 is looking at an in-person intake. In order to care plan, we have to have curiosity, we have to explore, we have to ask open-ended questions, be a good active listener. I'm doing a lot of blabbing here, I know that. Not to the extent that you may want to tease me about it, but when we're there in person, ask a question, explore a feeling, tell me more about that. Can you elaborate? This is what I heard. Did I hear you correctly? Is this what you mean? I heard this. And this is how I'm understanding it, which is an interpretation. I may not word it that way. Am I on the right track? Now, you might end with yes or no questions in terms of validating whether you're on the right track or not, but you're going to be doing a lot of exploring. And for every chapter, I'm trying to do like, what does this chapter mean to you? Learning objectives, key concepts. I cannot emphasize enough the foundation of every care plan, especially for end-of-life doulas, because we're looking at things differently than medical support personnel. We're looking at the physical impact. We're looking at the emotional impact, the spiritual, the social. We are genuinely holistic in how we approach things. And that is so, so critically important. What makes this chapter special and how it connects to your work. I'm going to be going ahead soon, shortly, but a lot of the chapters is here's an entry to it and dealing with live examples wherever possible, and there are case studies. And by the way, safety considerations beyond important. A lot of your intake, I know we're talking care planning, but here's the general scheme of things. We have often, and I encourage this to be a free consultation. We have a free conversation. 15 minutes, 20, 30, whatever your take. Thanks to input from Michelle Stewart. Michelle, I really appreciate you if you're watching this video. Uh, yeah, I was doing a 60-minute free consult, a free intake, and Michelle was like, no, you're giving away too much for free. I believe, Michelle, you were suggesting 15 to 20. I am not as, I may not be as good as you when it comes to exploration and gathering. I'm not saying you worked in the emergency room, but there's a reason why I never did. Because there are certain areas I am slow, whether it's my autism, INFJ, so I figured I need at least 30. But I did bring my initial consult from 60 to 30. And depending on the case, I may go and say, I might need to give a little bit more just for the initial information gathering. But you're gathering the information. And that's more often than not, that's going to be remote. It might be the phone, it might be Google Meet or Zoom or other virtual technology as they're being developed. But you're not seeing the house. I cannot tell you as a hospice nurse how many times I was given a picture of what to expect when I got to a person's home. And when I walked in the door, nowhere near. Everything from the ultra pristine, where I was afraid to where to walk and where to sit because it looked like everything came out of a catalog. We're talking about like, am I in the home of a billionaire? Multi-billion. I mean, everything looked like. Now my wife and I, my wife mainly is a cleaning person in the house, but we will never pass the white glove test ever. And if somebody came in even to the room where I'm filming, my MacBook Air that I have up on a stand just for aeration has dust on it. It's like, oh my word. But it's not a hoarding environment, by the way. It's just a little bit dusty. But I've got walked into houses where it's like, I did shower today. I'm wearing nice clothes, but oh my word, wow. But I've also walked into homes where it's literally, I am like, should I have brought in my backpack or nursing bag? It is beyond filthy. I've had hoarding. I still remember My one patient was a very sad case. This was during, I think it was the third, fourth, or fifth wave of COVID, where for those who were doing early detection, early treatment, close to 100% recovery rate, scientific based. If you have questions on that, I can point you to peer-reviewed scientific articles. Not to get into an argument, but this was a hoarding setting where literally I am sitting on a disconnected, I shouldn't say disconnected, it was a bedside commode out in the middle of the room, surrounded by other objects, that everything covered with dust, and just sitting down on, like, oh my word. I still remember my other hoarder. I had multiple hoarding patients where towards the end, when the brother came to visit and found the person non-responsive, it was in a section of a trailer I didn't even know existed because it was so like wiggle room to get to different places. And so you don't know what to expect. And for some people, whether getting to why this is so important for the intake, you're not just doing it to know how to care plan for the loved one that you're going to be taking care of. You're also asking yourself questions in a non-judgmental, non-discriminatory manner. Can I safely do this? Can I safely do this? Am I going to put my mental sanity or my life at risk? Now, we all walk a fine line in certain areas. Now, I just got done saying non-judgmental, non-discriminatory, but I also implied, Peter, are you leading into that you may not take on the case and you may turn people away? Transparency, as I try to do for all my conversations, whether it's recorded like this or in person. Yes, I'm talking about turning people away. Let's go over, I'm going to be dealing with my transparency, dealing with me. And I'm not saying that I would turn somebody away for this specific issue. I would have to see in person how bad it was while I was there. But I am highly, highly allergic to cats, anaphylactic level. Like scratch, I can die. Serious medical allergy. Um, that's not to say, like when I worked in hospice, and I still consider myself a hospice and palliative care registered nurse. I'm still looking for day shift, part-time, 8-hour or less here in Kentucky to complement my doula and everything else journey. Uh, but I've had multiple patients with cats where I didn't go to my employer and say, take me off the case. I've been blessed that every single case where they had cats is, number one, the overwhelming majority of the time, the cats were afraid of strangers, stranger danger. So when I would come in, they would scurry away. And normally, like, I love dogs. A lot of times I tease my families, I just come for the dogs. And to a degree, sometimes that was more true than not. But um, here, by them running away, that protected me. And in other cases, because I would let families know, and I'd have that as part of the conversation on the phone, they would often put their cats in a different room, and that would help. And then there were those also that, whether it's a different room or the cat's running away, uh, the house was clean enough, because some of my reactions are dander based. I found out about this allergy actually when I was in the IT field. I had started a consulting business. I'd started several business over my adult years in life, and this was back into PMP consulting. Um, and I went into a person's house, and they not only had these were cats that did not run away, but they not only were all around me, but the dander was so bad that after an hour in the home, and I was not scratched, but after an hour in the home, I had to leave the environment. I could not breathe. I could not see. I could not breathe. It was that bad. So I don't believe that's a type of discrimination to say, I can't do that. I can't do that. I'm judicious in it, uh, highly, but as you're doing your business, you do you. Remember, me do me, you do you. I'm not going to tell you how to run your business or your life. I'll encourage, but you do you. So, but I do believe as we're doing that in-person intake, we do have to ask because we are going into other people's homes. We are interacting with many different, if we're in a setting that can cause us either injury, illness, or put us in a state of mind that we are a help to no one else, those are questions we generally have to introspect and ask. And then ask, if I did this, would it be discriminatory? If I did this, would it be judgmental? What are the reasons for my thought process? And at the end of the day, you're answering to you. You're not answering to me, you're answering to you. And for me, this is stuff that I have prayer about. I go to, Jesus, Holy Spirit, Father God, tell me what would you like me to do? And so that you are aware in transparency. I've had cases. I still remember my literally my hardest from a ethical dilemma, emotional state. And this was pre-COVID. I was the primary hospice nurse for a loved one who was dying with HIV, and they did have active AIDS. And they lived in a very, very dilapidated trailer. I saw pictures of when they got it brand new. And for HIPAA and other reasons, I did not keep, nor would I'm not trying to shame anybody, but the state of that trailer and the state of the overall setting, it literally looked like it was out of the movies that you might see were they're literally garbage bags strewn out and garbage bags busted and stuff on the ground. This is just on the outside. And then you get in and it was a hoarding setting. We're literally, and I do mean this literally, not figurative, literally, I never walked on the floor. I would be walking and hear crunch, 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 crunch. It was never the floor. On the floor, there might be pizza boxes, either empty or you might see a slice or partially even eaten. There was like one day I went in, there was like a whole watermelon. Why is that on the floor? I mean, granted, the watermelon shell protects the watermelon from, you don't eat the shell, but it was a very difficult setting to be within. And then once I got back to where the patient was, who was completely bedbound, and I know in a way we're going a little bit off topic for the storytelling, but I believe you need to know because this is part of intake when you get it. Um, but this person, they had a hospital bed next to a single bed in the room, so the patient could be next to their spouse. So I understood the setup, but because of all the hoarding, I literally had my width. And I'm not that, before nursing school, I was up to 250 pounds. After nursing school, I've been in anywhere from the low 160s to the typically no higher than 180. It's been a chore, but I would literally be shuffling to get in between the wall and the bed in order to do wound care. And he had, I believe it was 5 to 7, literally to the bone pressure injuries on his backside and buttocks and legs. And I would be doing wound care where I had to remove the dressing, unpack, clean, in some cases with proper orders chemically, go through the debriding and proper procedures, measure, pack, redress, and all the while I'm wearing full PPE. Again, this is pre-COVID. We're talking about just trying to protect that you don't, like I was so worried at times that as I'm doing the care, I'm going to fall in to the patient. And this was a trailer that had no electricity. So I literally, because I would do on call, bought myself one of the mining cap things that I could put around that would be a lamp that I could actually go in and see, just because of the concern for falling. So I didn't ask to be relieved. I did ask for somebody to take turns with, just so that I would not mentally uh, burn out because of my autism, high functioning, and my basic personality type. Panic attacks can be challenging, and so these are things that you need to look at. But this does go over again. Some of these suggestions, take them as you will. You're going to do you. Do keep in mind odor. Do keep in mind odor. And you might say, well, I'm wearing perfume because I don't want to have an odor. Um, some people, I still remember when I first started working at Harrisburg Hospital in the cardiology unit, just as if any of you are familiar with essential oil, thieves oil is very good for the immune system, or so I'm told. And I would just literally a dab. I don't know if I did both ears or just the one. It would literally just be a dab. And I would do this a couple hours before going in. And I could barely smell it on me, but I still remember my one patient firing me as the nurse for the shift, saying, "Don't come back unless you are not putting anything on." And I had a talking to by a manager, stop putting on any essential oils. Any, just to be very clear. Um, as a side note, please comment down below if you know a good place to get a name tag or badge. I'm still really, really challenged with that in my own um, practice. And then this is where I am going to jump ahead. Please bear with me, as I shared before. I'm not saying this to be mean. This is not a free way to get the book over time. But I did want to jump down to just to give you some more room. Chapter 3 is going to be the virtual. So for those of you who are doing your doula practice and you're only doing it remotely, this is going to give you some thoughts, brainstorming guideline of doing a virtual intake. And so, and again, Grammarly with the suggestions. And I don't know, I'll come back to that later, not to take up your time. But let me get into one section and then we'll call an end for this video. But starting chapter 4 through, I believe, if going from memory, we just did the outline. I believe it's now chapter 11, is looking at the physical aspect. Remember, I shared as doulas, we're holistic. You have physical, you have emotional, you have social, you have spiritual. So you have the four pillars. So in the physical, we start off with cancer. Oh my word, with Grammarly. Grammarly. Learning objectives, key concepts, what makes the chapter special, how it connects to your work. One of the things that I try to do in every chapter that I'm writing is this is not just the patient or your client. I'm not sure if you refer to, and please comment below. Do you refer to as the patient, your client, your customer? What do you refer to the person of interest as? But back to holistic, I believe in we have to incorporate the family unit as whoever the patient calls family's family. And so that's very important as well. We look at brain cancer. And just not to throw you off, because some of my viewers are my fellow hospice and holistic nurses. Only nurses can assess. I love you first and foremost. I platonically love you. That's a level of dogma. I believe that when we explore, call it a different name. I'm using the name assess in this book because technically it is. But if it makes it easier for you to get over the legalistic wording, call it exploration questions, just to explore. I believe everyone could explore. Give you some example care planning. Again, this is mainly with the physical aspects. You may argue some of this is some of the other pillars. We go over some of the other types of cancer. Remember, just like dementia is an umbrella term, technically cancer is too, because there's various types. Goes over some common cancer care planning. Also, keep in mind if you've noticed any mistakes in the writing, please number one, please point them out in the comments below. This is a non-judgmental channel. I'm not going to argue with you. Depending on what you catch, I may even gift you with, I've done this before. I've gifted people either, I've had one person, they pointed out that I worded, I think it was 2 different paragraphs wrong in my hospice documentation book, the book my first published book. Not only did I end up correcting the book and republishing that, and sadly I can't get, Amazon doesn't give me a way to say, give the print version out for everyone who previously bought the book. And thankfully it was only 2, I should say it was 2 sentences, not 2 paragraphs. But I said to her, pick any of the books that I've ever published. I will send you that for free. And I've had other cases where, like Tanya Frazier, who just because of just giving input of you should write a book on breathing. Too many people jump on pushing oxygen on the external oxygen on the patient. Oxygen is a medication, and just because somebody is having trouble breathing does not mean you medicate with oxygen. There are so many other things that need to be assessed and explored and done, and oxygen is not the first on the list. So because of Tanya for that and patient rights, because of Tanya's input, I believe I wrote at least 2 books. I ended up sending Tanya a free book. I believe it was of her choice. So comment. I can't tell what the answer is going to be, but you don't know unless you try to brainstorm, share. Blood cancers, again, blood cancers, these are your leukemia. They can be extremely different for working with. And I'm gonna stop here again for a couple reasons, just being mindful of the time, because there's going to be an intro portion to this side of the video. And I do thank you for your time. I thank you for watching watching this journey unfold. Um, I'm still leery of giving a publication date for this book, especially since I did write chapter 8, by the way. Uh, but once I got into chapter 8, and I can't combine all the neurological disorders, I have to split this up. And what would be the best way to split it up? And realizing that this is turning from a guide. Most of what I like this to me, this is a guide. It is somewhat thick from a point of view, but it's, let me see here for a moment. Oh, I can, what am I doing? I'm trying to find the edge and I can just go to the table of contents. It's 13 chapters. plus a large number of appendices. Um, so I would call that a guide, but when we're talking about heading towards 24 chapters plus a whole bunch of appendices, that's more of a book. So I don't know if it'll be August or September. Also keep in mind that starting this week, this is currently, I filmed the day before I publish most of the time. This is Tuesday, July 29th. This is intended to be published Wednesday, July 30th. Thursday of this week, I am starting to turn this into a 14 to 16 week, I'm going to target 16 week course. So I have a lot on my plate trying to turn that into a course. I'm also developing the classes. I'm developing 2 classes. Think of a class as one segment of a course for communication. I'm doing the 101 basic communication for the end of life doula course, and I'm doing the 102 advanced communication class for the advanced end of life doula course for the International Doula Life Movement, plus all of the different continuing education courses, plus practicing them and just trying to be available for Anna and the other instructors. Peter, can you fill in for this or that while I'm building my own practice? So that said, again, comment, like, subscribe. I appreciate each and every one of you so much. Thank you for your time. Take care and God.